our channel. Today we are going to start the ischium muscle attachments. So first we are going to talk about ischial spine. So this is ischial spine. So mainly here you have the levator ani posterior. Most part it's levator ani muscle. It's taking its origin from the ischial spine, and also there is attachment of sacrospinous ligament over here. Okay, and also there's attachment to sacrospinal ligament, especially along its margins. Okay, and its dorsal surface is crossed by, so the same ischial spines, the ischial spine's dorsal surface is crossed by internal pudendal vessels and also by nerve to obturator internus. So remember these two, internal pudendal vessels and also obturator internus nerve. These are passing on its dorsal surface, crossing around the ischial spine. Okay. Next, coming to lesser sciatic notch. You can see this is a lesser sciatic notch. It is occupied by tendon of obturator internus. If you see here, this is obturator internus. So the lesser sciatic notch is occupied by obturator internus, and there is also a bursa which is deep to the tendon, and the notch is mainly lined by hyaline cartilage. The upper and lower margins of notch mainly give origin to superior. So this upper one will give to superior gemelli muscle, and inferior will give origin to the inferior gemelli muscle. So very easy. This lesser sciatic notch have obturator internus muscle origin and also superior and inferior gemelli muscles. Done. Now coming to the femoral surface. If you can see, this is a pelvic surface, right? So femoral surface, for that you have this diagram. You can see this is the femoral surface. Okay, this is an obturator occipital protuberance. Okay, this is obturator foramen. So this is a femoral surface. So mainly on the femoral surface of ischium, it gives origin to obturator externus. You can see this is obturator externus. So how to remember obturators externus and internus? It is very simple. On the external surface, wherever there is acetabulum, on that side there will be obturator externus muscle origin. Whereas whenever you see on the internal side or the pelvic side, there will be always origin of obturator externus muscle. Okay. So here will be obturator external muscle on the femoral surface. So you can see this obturator externus is actually forming a margin for the outer margin of the obturator foramen, right? And also there is quadratus femoris. You can see over here, this is a quadratus femoris. So this is getting its origin from the lateral border of upper part of ischial tuberosity. So lateral part of upper part of ischial tuberosity. Here is the ischial tuberosity, right? So lateral to it, it will get its origin, that is quadratus femoris. Done. So next there is also a dorsal surface of ischium, which has mainly relations like upper convex area related to piriformis. So it has an upper convex area which is related to piriformis, and the sciatic nerve and the nerve to quadratus femoris. So nerve to quadratus femoris, and the groove transmits the tendon of obturator internus. So you can see here, this is the obturator internus. So there is a groove for the obturator internus. So these all structures are mainly moving on dorsal surface. Okay. Now let us see the attachments of our ischial tuberosity. So this is ischial tuberosity. So what are the different attachments? The first one is superior lateral origin, superior lateral area, which gives origin to semi-membranous. So you can see this is a semi-membranous superior lateral origin. Okay, and also there is semi-tendinous and long head of biceps femoris. So long head of biceps femoris, semi-tendinous, all they get the origin from the your ischial tuberosity. Okay, and also the outer lower area gives origin to adductor magnus, outer lower area, and there is also the outer lower area to adductor magnus, and inner lower area is covered by fibrofatty tissue which supports the body weight in sitting position. So the sharp medial margin of tuberosity gives attachment to sacrotuberous ligament. This sharp one will give attachment to the sacrotuberous ligament also. Okay, and the lateral border of ischial tuberosity, lateral border. Okay, provides attachment to ischiofemoral ligament. So somewhere over here will be attachment of ischiofemoral ligament also. Okay, and just below the acetabulum. So just below acetabulum, here will be the ischiofemoral ligament. So actually here in this diagram only muscles are mentioned, but the ligaments we need to understand them. Okay, let's come into the greater part of pelvic surface. This is not a pelvic surface, right? This is the pelvic surface. So the greater part of pelvic surface, okay, of ischium gives origin to obturator internus. Which is obturator internus. This is the greater part of pelvic surface of our ischium. So actually lower end of this ischial surface mainly forms lateral wall of ischiorectal wall. Okay, ischiorectal fossa. So this lower part will form the lateral wall forms the ischiorectal fossa. Okay, let's come into attachments here. Attachments over conjoint ischiopubic rami. So for that we'll see this diagram. Here you can see this is actually the attachments on inner surface of right ischiopubic rami at this junction. Okay, mainly let us start with upper border. The upper border mainly gives attachment to obturator membrane, right? So for that you can easily understand why obturator membrane here. This is the upper border, right? It will give attachment to obturator membrane over here. Okay, this is a ischial conjoint tendon, right? Ischial conjoint here. So its upper border giving origin to obturator membrane, and the lower border provides attachment to fascia lata. Okay, lower border attachment to fascia lata and also membranous layer of superficial fascia or Colles fascia. So for that you can see here this diagram. This is a lower border which is giving origin to Colles fascia. Okay, of the perineum. Next come into muscles taking origin from outer surface. So from the outer surface there are obturators externus. Okay, on the outer surface obturators externus, and also have near the obturator margin of both rami the adductor brevis, chiefly which is coming from pubic ramus. So for that it's better to see another diagram. So you can see mainly this conjoint tendon, what are the muscles. So mainly on the outer margin you will see this obturator externus muscle. Okay, and mainly you will see the adductor brevis which is coming from the pubic ramus, chiefly it is coming from pubic ramus, and also our gracilis muscle just below it, it is also coming from the pubic ramus chiefly. Okay, whereas coming to the this muscle, that is adductor magnus is chiefly coming from the ischium ramus. So that is the chief muscle. So what is the chief muscle of ischial ramus? That is the adductor magnus. What is the chief muscle of pubic ramus? That is gracilis and adductor brevis. So there is adductor brevis, gracilis this side, and this side mainly from the ischium there is adductor magnus. And obturator externus is forming a margin. Okay, it's forming a margin for obturator foramen. So now comes this diagram. What are the attachments on inner surface? So mainly the upper ridge gives attachment to the upper layer of urogenital diaphragm. So you can see this is the upper layer of urogenital diaphragm. Okay, and the perineal membrane is attached to the lower ridge. This is the lower ridge, here gives attachment to the perineal membrane, and the upper area gives origin to obturatus internus. So this one, this upper area is giving origin to obturatus internus muscle, and the middle area gives origin to sphincter urethrae. So the middle area giving origin to the sphincter urethrae and to the deep transverse perineum. Even the deep transverse perineum also attached here. And it is related to dorsal nerve of penis. So it is related to mainly dorsal nerve of penis and internal pudendal vessels. So all these are forming this upper area. If you understand, this is the obturatus internus, this is middle part, and this is lower part giving origin to sphincter urethrae. Okay, and this is the upper layer of urogenital diaphragm, and there is also accompanied by dorsal nerve of penis and internal pudendal vessels. Okay, next coming to the internal pudendal vessels, and the lower area provides attachment to crus of penis. So this lower area gives attachment to the crus of penis and also gives origin to ischio-cavernous sinus and to the superficial transverse perineum. Okay, so this is all about the inner surface of conjoint between the ischium and the ramus of ischium and the inferior ramus of pubis, that is ischiopubic ramus, conjoint ramus. Okay, so by this we completed our muscle attachments of ischium. Now we'll start with acetabulum. If you know the acetabulum, right, this one here will be the acetabulum like this. Of course this is the inferior inner surface, on the outer surface will be acetabulum, right? So we'll discuss about it. So if you see this one, this is the acetabulum. Acetabulum is a deep cup shaped hemispherical cavity on the lateral aspect of the hip bone. Okay, and about its center it is directed laterally downwards forwards. The margin of acetabulum is deficient inferiorly. It is deficient inferiorly, and the deficiency is called acetabular notch. This is called as acetabular notch. It is bridged by transverse ligament. The non-articular roughened floor is called acetabular fossa. It contains mass of fat which is lined by synovial membrane, of course this area. And the horseshoe shape, this is horseshoe shaped articular surface or lunate surface seen on anterior, okay, superior, posterior parts of acetabulum. It is mainly lined by hyaline cartilage and articulate with head of femur to form the hip joint. and it is a fibrocartilaginous acetabular labrum which is attached to margins of acetabulum, which deepens the acetabular cavity. That's it. This is about acetabulum. Next we'll discuss about the obturator foramen. So this is a large gap in the hip bone situated anterior inferior to acetabulum between the pubis. This is pubis side, between the pubis and ischium. Okay, it is large and oval in males and small and triangular in female. So in female it will be triangular, small, whereas in male it's very large. And it is closed by obturator membrane which is attached to its margins, except at obturator groove where obturator vessels and nerves pass out of pelvis. So let us understand its ossification by this diagram. You can see this is the ossification of hip bone. So hip bone ossify in cartilage mainly from 3 primary centers and 5 secondary centers. So 3 primary centers and 5 secondary centers. The primary centers appear, one for ileum during the second month of intrauterine life and one for ischium. Where is ischium? This one. Okay, one for ischium. Okay, for ischium it will appear during 4th month. So for ileum it will happen, for ileum it is during 2nd month, for ischium 4th month, and one for pubis during 5th month. So 1, 4, 5th month. Okay, these are all 3 primary centers. Okay, so at the birth the hip bone is ossified except for 3 cartilaginous parts. These are iliac crest. So except at the birth the iliac crest is still not ossified. The Y-shaped cartilage which is separating the the Y-shaped cartilage which is separating the ileum, ischium and pubis, and a strip along the inferior margin. This one, a strip along the inferior margin of bone including ischial tuberosity. So these are all still not ossified at the time of birth. Okay, later they will ossify. Okay, next coming to the ischiopubic rami. This one, ischiopubic rami fuse with each other at 7 or 8 years of age. Next coming to the secondary centers. The secondary centers appear, you can see here the secondary center, this is a primary center. The secondary centers mainly appear at puberty. 2 for iliac crest, 2 secondary center for iliac crest, 2 for Y-shaped cartilage of acetabulum, and 1 for ischial tuberosity. The ossification in the acetabulum complete by 16 to 17 years, and rest of the bone is ossified by 20 to 25 years. The anterior superior iliac spine. This is the posterior anterior superior iliac spine, the pubic tubercle and the crest and the symphyseal surface may have separate secondary ossification centers. So now we are going to understand the difference between the male and female pelvic girdle, mainly hip bone. Okay, we are going to target on the hip bone between the male and female. So the characteristics of finding out whether it's male or female, let us find out. The greater sciatic notch. So coming to the greater sciatic notch, it is wider in females. So if you see the greater sciatic notch over here, it is wider in females. Okay, it is more wider in females than in males. Next coming to acetabulum. Here we can see on the back side. Okay, acetabulum is larger in males and diameter is approximately equal to distance from anterior margin to pubic symphysis, and the chilotic line extends from iliopubic eminence from ilium to pubic. The chilotic line is extend from iliopubic, and females the pelvic part of chilotic line is longer than sacral part. So in female the chilotic line will be longer when compared with the sacral part. Okay, and next coming to the curvatures of iliac crest. The curvature of iliac crest are more pronounced in male. You can see here less, but here they are more pronounced. So coming to the iliac fossa, if you see here, the iliac fossa is mainly deeper in males, whereas in females the pubic crest is shorter. So the pubic crest is shorter in the case of females. Okay, and the lower margin of ischiopubic rami is more everted. It's more everted in males. You can see, but here it's like butterfly, but here it's more everted. Okay, and for attachments of crus of penis and internal ischial spine, they are more everted. That is the ischiopubic rami. Okay, next coming to preauricular sulcus. This one here will be preauricular sulcus. The preauricular sulcus is more marked in females. In female the preauricular sulcus is more marked, and obturator foramen. See here, the obturator foramen is large oval in males, small triangular in female. Okay, and the subpubic angle, this one here, the subpubic angle The subpubic angle is more in female, that is 80 to 85 degrees. Okay, so this is all about the difference, that is determination of sex of our hip bone. So by this we completed the hip anatomy. Next we'll go to femur.